My brief is to talk about optimizing component alignment and soft tissue balancing in THR. Getting in the hip right indicates a good component positioning on the acetabular as well as the femoral side, some sort of biomechanical restoration based on the available femoral implants, and appropriate soft tissue balancing to optimize the functional outcome. As we all know, the surgical technique does not start with surgical incision. It starts much earlier with preoperative planning. Hip templating forces the surgeon to think in 3 dimensions, greatly improves the precision of surgery, shortens the length of procedure, and reduces the incidence of complications. One can anticipate the need for special implants, the varying needs of offset and neck lengths for that individual patient. Typically and conventionally, this was described as a 4-step approach, assessing the quality of radiograph, identification of anatomical landmarks, identification of mechanical references, and optimizing implant positioning to restore hip biomechanics. One must be aware of the influence of femoral rotation on the neck length as measured on the radiograph. And in order to be less dependent on the accurate radiographic setup, one can use calibration objects and make sure that the X-rays are taken in 10 degrees of internal rotation. We must identify the radiological anatomical landmarks like the teardrop, the hip center of rotation, the sourcil, the lesser trochanter width, the canal dimension, to look at the specifically what type of door classification this canal belongs to. Once we identify the anatomic landmarks, we must look at the mechanical landmarks. And typically, in the conventional thought process, it was the offset on the femoral side and on the acetabular side, which were referred to as femoral offset, and the acetabular offset, the neck length, and similarly to look at the center of rotation of the femur and acetabulum. And finally, this included the positioning of the implants with the main aim to restore the original hip anatomy and biomechanics. And it was considered that it is easier to template the healthy contralateral hip to mirror the result to the pathological side. Although intuitively this approach is extremely compelling, it is has been shown of late, especially with the works of Abdel et al., who showed that positioning the implants in the safe zone itself was not an insurance against instability, and that the 3D picture and the spinopelvic parameters and pelvifemoral parameters are dynamic in nature, and trying to replicate the 3D biomechanics of the hip just by restoring these parameters using the available implants may not be the practical approach or the way to go. If you see X-rays like this, where there is an obturator oblique type or an iliac oblique type of views, where there is an inlet outlet type of views which are available like this, we must definitely evaluate the spinopelvic parameters using sitting and standing lateral radiographs with the spine and pelvis to see if there is any issue with that. Now, conventionally, the femoral templating was to re-establish the center of rotation by calculating the discrepancy between the femoral center of rotation and the acetabular center of rotation, restoration of the combined offset, especially on the femoral and acetabular side, and incorporation of leg length into this particular arrangement to make sure that the acetabular and femoral center of rotations matched with each other at the end of the surgery. Now, there has been a shift in paradigm with respect to the surgical techniques. We have the Biberland pathway, which looks at independent restoration of femoral and acetabular heights by positioning the acetabular component at the level of the inner margin of the transverse acetabular ligament and recreating the femoral neck length and offset options and calibrating this particular thing based on the head size and the liner thickness so that you don't change the leg length or restore the leg length to pre-arthritic level. And we have this functional 3-dimensional balancing approach, which has been published by Dr. Bose et al., which incorporates the use of leg length stitch and the antiversion wedges in order to have a 3-dimensional orientation of the hip to restore the combined parameters of combined antiversion, global offset, and composite length, which makes more intuitive sense in the modern day. Now, there is enough evidence to suggest that acetabular component positioning using the TAL as a guide works in majority of the situations. And this is the sort of picture one must look to achieve, where we are trying to position the component along the inner margin of the transverse acetabular ligament. This restores the acetabular center of rotation. It restores the anteversion of the acetabulum, and also in most of the cases, acetabular inclination to the native acetabular position. While preparing the uncemented acetabulum, it is important to achieve 3-dimensional exposure of the acetabulum and make sure not to medialize the cup too much. Just make sure that the cup is positioned along the inner margin of the transverse acetabular ligament. One has to achieve what we call as the anteroposterior fit between the anterosuperior and posterior-inferior columns, and also a stability at a direction perpendicular to that, which is referred to as a superior inferior toggle. So once you achieve this with the reamer, there is also an important tip. We must measure the head diameter and make sure that the cup is not more than 4 millimeter larger than the head diameter. So if you have a 46 head diameter, it is good to get a 50 cup inside. And if you are over reaming the acetabulum, then we will damage the bone. For screw placement, the safe zones, one must again look at the line connecting the anterior superior iliac spine to the ischium, and because of the lateral position in the posterior approach and the acetabular anteversion, the 12 o'clock position actually appears to be more anterior than you think. It appears like the 10 o'clock position, and this must be recognized, and the appropriate positioning of the screws is identified by correctly identifying the 12 and 6 o'clock positions of the acetabulum and positioning the screws in the posterior superior and anterior superior parts of the acetabulum in order to keep them away from the neurovascular structures and to get good fixation into the acetabular dome. So this is an important concept, the screw placement safe zones. We must recognize special situations, the acetabular protrusio and the acetabular dysplasia, where we will have to lateralize the socket judiciously or medialize the socket in order to get the hip at the center of rotation. On the femoral side, the level of neck cut is important. It is important to identify whether we have an isohomothetic stem where the neck length is constant or the neck length varies with the increasing diameter of the stem. If you have a isohomothetic stem, you can use the trunnion as a guide for your neck resection, and that is very reliable. And typically in a short varus neck, you will have a neck shaft angle which is less than 130 degrees. You will have to take a low neck cut and use a stem which is appropriately positioned with a low neck length and a higher offset. At the same time, when we have a long valgus neck, you will take the neck cut predominantly in the upper third of the neck of the femur and use a stem with a low offset and larger neck length. So it is important to identify and recognize various types of door classification and tailor your techniques accordingly to get good fixation with the cementless stem, especially in the door type A while using stems like Corey. We have different offset options which are available, and these must all be kept in view because we will not be able to replicate the hip length and the offset of individual patients using a single implant in each case. So with Corey, you have the option of a KA, KS, KHO, and KLA, and the collared option available as well. And these have different neck lengths and offset, and based on the patient's anatomy, you will have to tailor the stem side with the closest match to the neck shaft angle and the closest match to the neck length for that particular patient. Regarding the stability considerations, once we restore the combined anteversion, the combined offset, and the composite length, typically the hip will be stable, and we must not aim to make undislocatable hips where the hip is tested at the extremes of range of motion, and the hip now appears to be unstable because you have cut all the soft tissues and you're keeping on increasing the neck length and offset for that particular patient and making very tight over lengthened limbs. So this is important. We must look at the combined anteversion as a parameter, try and restore it to 35 degrees in men and roughly 40 to 45 degrees in women. And once we do that, typically the hip will be stable. We must try and optimize the head-neck ratio, create impingement-free range of motion by removing the anterior osteophytes and restore the previous mentioned parameters. Coming to the soft tissue evaluation, it is useful to do trial reduction. You must look at the sleeping position, inflection and adduction. You can look at extension, external rotation. There must be at least a centimeter of space between the greater trochanter and the ischium. And you must have stability assessment, both in flexion as well as extension. You must look for residual flexion contractures and make appropriate releases of the reflected head of rectus humerus and anterior capsule in cases of significant residual flexion contracture as shown by the dropkick test. Sometimes you may have to do a Yount release or a release of the ITB as well in order to balance the particular hip. If you check the hip in abduction and around 30 degrees of flexion and it is tight, then that indicates anterior-inferior capsule tightness, and this can be appropriately addressed as well. The leg length can be addressed either using the coaxial stitch or infracotyloid pin. These two are the methods. With the coaxial stitch, you can also look at the combined offset as well, and it has been elegantly described by Dr. Vijay Bose in his paper. Lastly, one must recognize difficult hips. You must recognize the patterns of supratrochanteric shortening, where the distance between the ilium and the tip of the trochanter is foreshortened, and these cases, the abductor mechanism is tight. You must look at cases with subtrochanteric shortening, where the lesser trochanter is at or above the level of the teardrop, and the relationship between the head and the greater trochanter is maintained. And some cases do have a combination of supratrochanteric and infratrochanteric shortening. And these difficult femoral situations must be identified beforehand, and appropriate implants which have got versional freedom as well as craniocondylar adjustment capability must be used, like the Kohn-Wagner or SROM in these particular cases. When we have supratrochanteric shortening, the strategy is to sink the stem deep and use a stem with versional freedom like the Kohn-Wagner. And whenever we have a subtrochanteric shortening, you will have to anticipate the need to do subtrochanteric shortening osteotomy, in which case an implant like an SROM is probably a better choice. Thank you very much.